Hello, welcome to Welltech Medical's webinar series. In today's webinar, consultant psychiatrist Dr. Nishchint Warikoo is going to talk about ADHD, attention deficit hyperactivity disorder. He will also address some questions that were put to him on the topic in advance of the live session. If you would like to receive notifications of future webinars or are interested in any of our services that Welltech Medical can offer, please visit our website, welltechmedical.com, or like and subscribe to this page. Thank you.
Though people talk of ADHD, there is something called ADD as well. So the difference between ADHD and ADD is, in ADD, there is inattentiveness that's present there and impulsiveness is present. The thing that's missing is hyperactivity. Now, that creates a bit of a problem because children with ADD often are not diagnosed or picked up for a diagnosis because they're not hyperactive. The difficulties often which other people see is around hyperactivity. Whereas these children who have ADD might be sitting in the class, not able to concentrate, daydreaming all the time, but because they're not creating problems for others, they don't get noticed and hence might not get the right support in right time. So that's a thing to watch for, which we as clinicians are always careful about. Then moving on to the age, usually you'll see because ADHD is a neurodevelopmental disorder, that means it's a disorder which is present from the birth. So a person or a child can't develop it later on. If they have it, it will be present much before they are 5 years of age, and it will be noticeable before that. It's hard to get this diagnosis later on. Now, again, coming to inattentiveness and hyperactivity and impulsiveness, it might be a good idea to just talk about the things which we'll see if a child is actually inattentive. So the main signs of inattentiveness are having a short attention span and being easily distracted. So the child is sitting in the class, teacher is teaching something, they will be able to focus, let's say, for 3 minutes. There's a slight noise in the room somewhere and they get distracted. Their mind goes from the teacher to that place, and then by the time it comes back, teacher has taught something else, the child can't understand, goes away again mentally. So that's one of the key things. The second is being unable to stick to tasks, particularly if they're tedious or time consuming. So if they have been given homework, which may take 1 hour, it'll be difficult for them to sit down and do that homework. The next one would be constantly changing activity or tasks. So if you see a child in a classroom who has ADHD, you might see other children doing a task and following it through the steps that need to be done. But a child with ADHD might move from one task to another, and it's also quick. Hence, they're not able to complete the task that needs to be completed. And they will also have difficulty in organizing their tasks. So a child with ADHD in the morning who is supposed to get ready to the school might put on the socks, but then forget to put on the shoes and get distracted and be doing something else, which would take them a lot of time then to get ready for the school. The child who has inattentiveness might make lots of careless mistakes, example in schoolwork. They might appear forgetful, or they might be losing things. Often parents tell me, oh, my child has lost 4 jackets this year, or he never has a pencil on him because he has lost it, or his uniform, we have to keep on changing it, and that's so common. They may appear to be unable to listen to or carry out instruction. Now, this is very important because often parents get annoyed because they have told the child to do something. The child was listening to them, apparently, and then didn't do that. And they feel that the child is purposefully not listening to them. But what has actually happened is that the child has not been able to take in all the instructions. And often what parents tell me is, if we give our child instructions, let's say 2 or 3 instructions, the child would only remember the last one. So if we tell the child, go upstairs, go into the room on the right-hand side, find let's say a pencil box and find a towel, they will find that child would go upstairs and probably get the towel and nothing else. So that's inattentiveness. Then if we look at the symptoms of hyperactivity and impulsiveness, often what you would see is a child who is unable to sit still, especially in a calm or quiet surrounding, most often in the classroom. So all the children are sitting down doing their work or listening to the teacher, but there's one child who has, let's say, ADHD, is not able to sit still, would get up, would want to be talking to other people. Similarly, you would also see constant fidgeting. They'll be fidgeting all the time. So that's also, that might be either in the classroom or at home, or even if when I see them in the clinic, you will see these children who are fidgeting all the time. They might be unable to concentrate on tasks, as we mentioned earlier. You will see lots of physical movement. If a child is sitting in the clinic in front of me, I'll see the child would be moving around, would be picking things, would be probably switching on the light bulb or turning the fan on, and often I have to ask them to stop doing that. So there's lots of physical movement. They might talk a lot, and they might interrupt other people's conversation. They might also be unable to wait for their turn. So often parents tell me, if we have to stand in a queue, there is no way he can stand in the queue or she can stand in the queue. And many a times I have to write letters supporting the parents if they are going to, let's say, a recreational center, a park, or even for if they're traveling international, to help them at the airport so that they don't have to wait in the queues for a long time. And last but not the least is acting without thinking. That's the impulsiveness and little or no sense of danger. So the children with ADHD often would have lots of accidents when they're little or when they haven't been diagnosed or treated. And there's a history often that I get of a child having broken bones or lots of falls or accidentally walked in front of a car. So that kind of thing. So there are lots of risks associated with ADHD. Now, these symptoms can cause a significant problem in a child's life. So it could be in form of underachievement at school. They might have poor social interaction with other children. The research tells us that if a child who has ADHD and is not being treated, if they go in a new group of children and start playing with them, it doesn't take much time for other children to notice that there is something not right here. And the children often get rejected from the group. So that's an important thing for the children. And it also impacts their relation with adults, and they have a problem with discipline wherever it's needed. So that was, in a nutshell, what ADHD and ADD is. Now, if I see a child with ADHD and ADD, I won't be doing justice to the child if I'm just focusing on that. The key thing is to also look at the comorbid conditions, that is other neurodevelopmental problems or mental health problems which might be associated with ADHD. Because if we don't consider them and only treat the ADHD or ADD, the child would not benefit from it. They will continue to have problems. So the key ones that I often see is anxiety disorder. So a child with ADHD most probably would have anxiety disorder if the diagnosis has been delayed or if the treatment has been delayed. And how do you notice it? It's usually that the child is worrying a lot. They're nervous most of the time. It may be because there are lots of physical symptoms also present, such as they might be having rapid heartbeat, they might be sweating, and there might be dizziness, so on and so forth. The next one is depression. Lots of children who haven't been diagnosed in time and have had anxiety for a long period of time later on can develop depression. So whenever we are assessing a child, we need to bear that in mind. The other two are oppositional defiant disorder and conduct disorder. Mainly what these are that the children would oppose any authority figure and they wouldn't want to do what is socially accepted and what are the social norms, so they might not stick to them. So a child with conduct disorder might end up stealing, fighting, harming people or animals. So this is also important for us to diagnose. Children with ADHD and ADD, they might also have the diagnosis of autistic spectrum disorder, which affects their social interaction, their communication with others, and has an impact on their interests and behaviors. Often we also see sleep problems. So children with ADHD, they'll find it difficult to go to sleep. There are lots of reasons for that, which I will come back to later because one of the questions is around that. Children with ADHD and ADD also might have epilepsy or children who have epilepsy might present as if they have ADHD. Other diagnosis is Tourette syndrome, or what we commonly call tics. That's also often seen with children who have ADHD and does need to be treated separately. We might also have learning difficulties such as dyslexia. And one key problem that often we need to be aware of is sensory difficulties. So children with ADHD might have sensory difficulty, and if we don't manage that, then we won't be giving them effective treatment. I spent quite some time summarizing all of it because this is very important for you as parents, for you as professionals, and for schools and teachers, because bearing all of this in mind is important, because when we're doing an assessment of the child, when we're trying to understand the child, we need to bear all of this in mind. When we are then planning a clinical management plan, we need to know what the comorbidities are in addition to the diagnosis. And this understanding would also help schools to put in the right support in place for the children. So that was talking about ADHD and the comorbid conditions. Now I'll move on to the second part of the webinar, which is answering the questions that have been put to me. So if I start with the first question, the question is, can you talk about the link with sleep disturbance? So as I said earlier, we'll be talking about this. I would be using the abbreviation DCM often in this talk. It's nothing research based or something. It's just something that I use because it reminds me that whenever I'm considering a child with ADHD, am I checking that their diagnosis is right? B is C, that is, am I checking whether they got comorbidity? And third is, if they are on medication, is the presentation due to a side effect? So when we're talking of sleep disturbance, I'll again use the same way of looking at the problem. So first of all, we need to check whether the child has the right diagnosis. Do they actually have ADHD? Or are the symptoms present because the child has sleep difficulty, sleep problem, and that sleep problem is causing some presenting as if the child is has got ADHD, because if they're not able to sleep well, they won't be able to concentrate. They might be irritable, which will make concentration even more difficult. So is that the reason why they are presenting the way they are? Now, if they have diagnosis of ADHD, then does the child have anxiety? Does the child have depression as well? Because if they have ADHD and they have anxiety and depression which is not being treated, then it's highly likely that they won't be able to sleep. The third one is, if the children with ADHD have been given medication, hence going to the M, the medication like stimulants, are the stimulants causing any side effects? So one of the key side effects of the stimulant is it has an effect on the sleep, particularly if a child is taking long-acting stimulant medication, it would act till, let's say, 7 or 8 p.m. Then we often see almost a rebound hyperactivity because the medicine is out of the system. The ADHD almost seems to come up again, and because the child is now hyperactive, they find it difficult to go to sleep. And last but not the least is, does the child have a sleep problem? Do they need to be seen in a sleep clinic? Is the sleep problem different from ADHD? So when we are doing an assessment for ADHD, when we're starting on medication, the key thing for us to find out is whether the child actually has a sleep disturbance even before we start them on medication, because then we can help them with that. The next question is best management strategies for parents when children have, I think it says volition, but I think it is violent episodes, how to avoid them and how to de-escalate them before they happen if possible. So I would treat that question as if you're asking me, the child has violent episodes. Now, if we want to help the child with their violence, that is when they are getting violent to other people, it would be helpful to understand the child, to see the world from the child's eye, to know why the child might be getting angry or why they might be presenting in this form. If we take an average child with ADHD, they would probably present with ADHD symptoms from the time they start walking. And often, because the impulsivity is there, hyperactivity is there, they can sometimes be labeled as naughty children because they're not doing the things that they're expected of them. And when they are told not to do that, what they have done, often children learn once the parents tell them not to do what they have just done. But because these children are impulsive, they tend to do the same thing again. It's difficult for them to learn from one experience. And then parents start feeling that the child is not listening to us, and there can be lots of anger towards the children. So this almost misunderstanding of the child continues. It can start at home if they have not been diagnosed. Then when they reach school, again the same thing because of the concentration problems and them not being able to follow the rules. They might be labeled as naughty children in school as well. And the children, when they're told off so many times, they do want to make changes. They do want to make things better, but unfortunately, it seems out of their control. So there's a sense of not being in control, and that can then affect their self-esteem. So the self-esteem can get worse and worse if they're not understood properly, and it can lead to anxiety. So now you have a child who is very anxious, who has very low self-esteem, and then the chance of them reacting to even simple things in a very strong way is quite high. So something like a small remark by a parent, which probably wouldn't be hurt other child, might hurt these children because they already have low self-esteem. So that can then make them more defensive, more angry, and then more violent. So again, one of the ways I look at it, and I often talk to parents, is that if you see an angry child, use the abbreviation LAP, LAP as in a parent's lap. And what it stands for is L stands for love, A stands for, so it's love. Are you giving them enough love? Are you giving them protection? Are you protecting them enough? Because if you're giving them enough love, that would make them feel good about them. Or giving them protection, that would make them feel safe. And are you understanding them? So that's important for them. Is the parent understanding them? So love, understanding, and protection are the important things to think about. So if a child is violent, we need to think about, is the child feeling safe? If the child is not feeling safe, then they won't be able to manage their behavior. If the child is not feeling loud, they won't be able to manage their behavior. And if they're not feeling understood by the parent, then that's going to get worse. That doesn't mean, and I'm not saying we have to let children get away with whatever they are doing. No, there have to be boundaries. And boundaries are important as well, because if we don't have the boundaries, then we're not teaching them the social skills. So if there is some action, there has to be consequence. But in case of ADHD children, the third or the complicating factor is their impulsivity. So if they're doing an action, we're giving them a consequence, they're still not learning. That means they need medication so that reduces their impulsivity and they learn from consequences. So it can be complex in that form, but if it's understood properly, we can help these children. There is no way that we should not support them enough. And if there's low self-esteem, not only medication, we can look at psychological therapies like CBT, like psychoanalytic therapy, to help improve their esteem, help them feel better about themselves, and there will be less chances of having any such episodes again. Moving on to the next question, which is advice on reviewing the different types of ADHD medication that are available. So that's a very good question, because there are lots of different types of ADHD medication. They are like stimulants, then there is something called atomoxetine, then guanfacine. So different types of medication who are from different families of chemicals. So going back to what I was saying earlier about diagnosis, about comorbidity, and about the medication side effect. So first of all, a clinician needs to decide whether the diagnosis is right. So if someone has ADHD, then obviously they'll need medication for ADHD. That's the first step. The second step is comorbidity. Is the child having other problems, let's say anxiety or depression? Because if they are having that as well, that would help decide the medication. Giving an example, if a child has ADHD, a stimulant medication is the first line treatment and we should give that. But if a child has ADHD and they have anxiety and depression as well, then we might decide to give them a medicine called atomoxetine, because that medicine helps with anxiety as well. So comorbidity kind of defines the medication that we give. Then the next thing is side effects. Now, most of the ADHD medication in the form of stimulants, they have a side effect as in it has an impact on the appetite of a child. So if a child is not eating or they're underweight, then we would prefer not to give them a stimulant or give it in a way where we can monitor the food they're eating and have regular checks on that. We anyway do that because if a child is started on stimulant medication, we check regularly their height, their weight, blood pressure, and pulse. That's done regularly. So these are some of the things that we think of before giving a particular type of medicine. Then also if a child has ADHD and they have severe behavioral difficulties, then we might consider a medication called guanfacine. That's often helpful. If there are comorbid conditions like sleep problems, then we might need to consider whether we would just give ADHD medication or should we also give something for the sleep like melatonin. So this is a general description, but obviously the decision would need to be tailored to the child, and that's very important. And going back to what I said earlier, just a diagnosis of ADHD doesn't define the medicine that must be given to the child, but what defines is the need of the child, including any comorbid conditions, any other problems the child is facing, and the need of the child. So it has to be tailored to each child. You can't use the same medication for every child. Moving on to the next question, the question is, can we have help with regards to studying for GCSE with ADHD? So if a child has ADHD and they have got GCSE exams coming up, what kind of help could they have? I think it's for helping a child with ADHD, it has always to be a teamwork. The teamwork is clinicians, parents, school, all three have to work together. So the clinician's job is good diagnosis, good understanding of the condition, and the right medication for the child or the young person, most effective medication. So if that's there, the child would or the young person would find it easy to take the exam. Second is the parents. Parents need to focus on the child's mental health, understanding the child and helping them develop their self-esteem. So if the child is feeling happy, it's much easier for them to concentrate. If they're feeling sad or they're upset, they'll find it difficult to concentrate. That goes for every child, even if they don't have ADHD. So that's the parent's job. And the school need to have a good understanding of what ADHD is, and many schools and most of the teachers do have that understanding. And the school can often make some exceptions. Some schools do have flexibility with supporting the children who have ADHD. Sometimes they would give more time for the exams, or they will support them like giving a separate room to take the exam where there's not much of distraction. So those kind of things can be done to help children who are taking GCSE and have an ADHD diagnosis. Moving on to the next question. The question is CBT effective as treatment if ADHD is more about executive function? So this is a very interesting question and very important as well, because going back to what I was saying about diagnosis, comorbidity, and medication side effects, in this situation, the diagnosis is very important. Because if someone has cognitive deficit of working memory or short-term memory, that might present as ADHD. So the diagnosis is very important from that point of view. So that's one thing. The second thing is comorbidity. Now, if a child has ADHD and they also have anxiety, or they have ADHD and they have depression, then CBT would be very helpful because it will help with anxiety, it will help with depression. And once the anxiety and the depression are better, then we'll have better ADHD control. The third thing is behavioral difficulties. And because children with ADHD have behavioral difficulties, and if they can be helped by giving cognitive behavioral therapy, which focuses on behavior, then it's definitely going to help children with ADHD. So yes, it will help. And also the other key thing is low self-esteem, because children with ADHD have low self-esteem. If they're supported by giving CBT, then that would help with the low self-esteem. And any improvement in the comorbid conditions would also lead to improvement in ADHD. So we can only effectively manage ADHD if we have looked at all the comorbid conditions and we have supported the children with that. Moving on to the next question. It says, our son's mood generally sets the tone of the household. There are two other siblings in the house. When it's negative, then I think what the question is that when the child's mood is negative, then it has an effect on the whole household. And the question is also, are there any strategies to pull it back to a positive environment? I think the simple question is yes. And but there is more detailed answer I'd like to give to this question is, if there is anyone in the family who has a difficulty, who are going through a difficult time, then it is going to have an impact on the rest of the family. So that's a key thing, whether the child has ADHD or not. So just like if a family member has, let's say, a broken bone, a fractured leg, and they're not able to walk, then it will have an effect on the rest of the family. But what the family would do is have a good understanding of the problem the child has. They will be supportive to the child and make the child feel okay about it. So the same thing goes with ADHD. If a child has ADHD, we need to bear in mind, are we understanding the child's problem from their point of view? Are we supporting them enough? And are we giving them enough love? So these key things are important as a family. So it's just like, as I said, if one member of the family are going through a difficult time, the rest of the family has to come together to support them. And once the child feels supported, then they would respond very well, and the whole family would, as you said, go into a positive environment. But it's easier said than done, and sometimes it might not be possible for you as parents to do it on your own. That doesn't mean you're not capable of doing it. It just means that the child's difficulties are much more, and you need professional help. So in that situation, again, going back to the diagnosis, check whether the child has only ADHD or do they have other comorbid conditions, then that might need to be treated. So get it checked with a clinician. Sometimes family therapy is a very good form of therapy, which helps the family understand the problem, helps them support each other. So that could be other important thing. And the third thing is, as I said, there is a comorbidity in form of oppositional defiant disorder or conduct disorder. If that is the case, then you as parent would have to set the boundaries for the child. And again, going back to the teamwork, you as parents getting feedback from the clinician, getting feedback from the school, and seeing a pattern of the child's presentation. If you see the child is presenting as very oppositional in school, at home, then you know it's a problem which is prevalent everywhere. Whereas if the child is doing that at only one place, then probably it's something about the environment which is making the child behave in that way. And there might be some environmental adjustment that would need to be done. So what do we need to do in this case? If we just go back to the key things, one is understanding of the condition, B is being supportive of the child, and C is teamwork to understand and support the child. I'll move on to the next question now, which is about medication. Sorry, there's a question that has come up which says, what type of clinician gives family therapy? So family therapy is given by clinicians who are called family therapists. They are trained as family therapists, and often all the members of the family would be invited to join in the family therapy. And it's flexible as well, because once they've met the family, then there could be some sessions which could be just with the parents or just with the children, or there can be various ways of doing it. And I, in my clinical practice, have found it one of the best therapies and with the really good results. So I would always recommend family therapy if I feel there's a need. Going on to is medication. There's a question that we're struggling to get a balance with it. My son needs it, as otherwise he can't concentrate at all. But with it, he experiences loss of appetite and finds it hard to sleep. Any advice and or any other options? So again, as a clinician, I would see this young person and would check whether my diagnosis is right. Is it just ADHD, or are there other things which are making it difficult for them to concentrate? But in this case, it seems it's the medication which is causing loss of appetite and is affecting the sleep. So if I first take the loss of appetite, it's common with stimulants that there'll be loss of appetite, but that doesn't mean that we cannot manage it. Managing is key thing. Often I ask the parents that if their children are finding it difficult to eat after they have taken the medicine, they should have breakfast first and then take the medicine. They should try to give them snacks so that in lunchtime they're able to eat, even if they want to eat little, but they can. In the evening, often once the medicine effect wears off, they will feel very hungry. And it's not uncommon for children to raid the fridge late in the night because they're feeling so hungry. So it's a good option to give them a good dinner, and then if they want a snack, keep snacks somewhere so that they can have it when they want it. So that should help with the appetite. And whenever we start the stimulant medication, we do monitor the children. We monitor their height and weight. Usually it's done 6 monthly. So if we find that loss of appetite has then led to weight not being gained or height not going as per the norm, then we would consider reducing or stopping the stimulant medication and going to a different medicine which does not cause appetite loss. Similarly with sleep, when we diagnose someone with ADHD or when we start them on medication, we would check whether they are finding it difficult to go to sleep. ADHD itself can cause sleep difficulties. Because of that, if they're not able to sleep, then we could consider giving them medicine to help with sleep, which can be melatonin. Sometimes the sleep problem can be a result of comorbid conditions like anxiety, like depression, or even sensory difficulties. Then those need to be addressed. And the third thing is if the sleep is because of, as I mentioned earlier, ADHD medicine, long-acting, can have an impact on the sleep because by the time they wear off in the evening, there can be rebound ADHD. That doesn't mean stop the ADHD medicine. What we sometimes do is give a top-up of the medicine in the evening. That again controls the hyperactivity and helps the child go to sleep. So it's not necessary always to change the medicine to a different one. You could do a bit of change in the dose and additions here and there, and then that can help the child, particularly if that ADHD medicine is effective for their ADHD symptoms. So yes, you can change the dose of the medicine. You can add medication like melatonin to help with it, or you can change the medicine to a different type of medicine which doesn't have these kind of problems like appetite suppression or difficulty to go to sleep. One particular medicine I would suggest is atomoxetine, because that stays in the system 24/7 and doesn't have highs and lows like stimulants have, and hence might be good for sleep. So that was that question. We're moving on to the next one. The next question is inattentive type, ADHD inattentive type with atypical benign Rolandic epilepsy. Should the ADHD be treated currently under CAMS and trying various ADHD medication, or the epilepsy should be treated? So the answer to this question is, again, it's similar to what I was mentioning earlier, is diagnosis. Is the diagnosis right? Does the child have ADHD, or is it just a presentation of epilepsy? If we know that they have ADHD and they also have epilepsy, then ADHD would need to be treated on its own, and epilepsy would need to be treated as well. Often I, as a clinician in CAMS, work closely with the pediatricians who are treating the epilepsy, because then we can fine-tune the medication or make changes to the medication based on what's been given by, let's say, the pediatricians, or what we are giving from CAMS, and then that coordination. So teamwork is very important in these kind of conditions, but there is no blanket rule that whether we should give one medicine or not, or whether we should just treat one or not. Often it's important to treat both of them if both of them are present, because if we are not treating ADHD, then they would find it difficult to gain academically, and it will affect their social relations. So yes. Moving on to the next question. It says, can you explain a little more about rejection-sensitive dysphoria and its link to ASHA? My son has an ADHD diagnosis, but is very low energy. We don't really understand the hyperactive element to the diagnosis, as he's anything but hyperactive. I think, again, to answer this question, we have to go back to what I have discussed earlier. Diagnosis. Is the diagnosis right? Just because the child isn't hyperactive doesn't mean that they don't have other bits of ADHD, because the child could be actually having ADD, where they have attention problem and impulsivity, but not the hyperactivity element. So yes, that's a possibility. The other thing is, if the child is hypersensitive, has sensory difficulties, has anxiety, has depression, they might present with low energy, they might present with loss of focus, loss of attention, they might present with irritability. So it's important to check, are there any comorbid conditions, anxiety and depression? So it'll need a comprehensive assessment by a consultant or a psychiatrist from the CAMS team to find out what is the actual diagnosis, what are the comorbidities, and are the problems with low energy also possibly due to side effect to the medication. So a comprehensive assessment is important. Sorry, I can't answer that question directly because it needs more assessment. Moving on to the next question, it is the crossover between ADHD and sensory processing disorder. Please, could you explain what the distinguishing attention factors are between the two? Because it's very tricky to work out whether attention difficulties come from one, the other, or both. Do the symptoms of attention differ depending on what it is caused by? A very good question again, and very close to my heart, because if I am treating a child with ADHD and they have sensory processing difficulties, then whichever treatment I give, if I haven't supported them with their sensory processing problems, then it won't be effective. Because it's like an example I often give to the parents is, if they are sitting at their work desk and they're trying to concentrate on doing some work, and someone comes and starts shouting in their ear, or there is a loud noise in the air constantly, would they be able to focus? The answer is no, they won't be able to focus. So similarly, if a child has sensory difficulties, let's say the child is hypersensitive to noise, then any noise which might not distract others might distract them a lot. And if they're distracted, they cannot attend to whatever is in front of them. So a diagnosis, sensory assessment is very important, because that will help you with knowing what kind of support is needed for the child. Giving an example, if a child is sensitive to noise, and then we get them an earmuff that blocks out the noise, they will be able to concentrate very easily. So there are simple solutions to that, but the key thing is understanding what is causing this problem. So it can be managed that way. Next question is, what's the best way to motivate behavioral change? I think to motivate behavioral change is, first of all, understanding the child. Because if we use our own example as a person, as an individual, as an adult, what motivates us to do something? To begin with, we need to have something that we want to do and aim and target. Second is we should feel calm. We should not be anxious. We should not be low in mood. If we have any of that, we won't be able to do that. We won't be able to strive towards achieving something. And third is the supportive environment. Let's say as parents, if a child wants to, let's say, run a marathon and the parents are not supporting the child enough, then they won't be able to do that or achieve that. So all of these together, they have to be brought in so that we can help the child achieve what they want to, or if there's a behavior we think would help the child to get them into that behavior, we have to help them understand what is the benefit of that behavior. B, they need to be supported regularly with doing that behavior, and C, if it's done persistently, they would see the benefit of that behavior, and then they would continue to do that. So that's a way of doing it. The next question is, can ADHD be linked to anxiety, and if so, why, and how can we help? I think I've answered this question earlier. It is anxiety is often present with ADHD, and it does need to be treated separately, either with psychological therapy, which could be CBT, which could be psychodynamic psychoanalytic therapy, or a medication for anxiety can also be given if it has not been able to manage well, or if it's having a major impact on the functioning of the child. The next question is ADHD. As they age in teens through adulthood, what happens? So often I use a thumb rule for ADHD, that is 1/3, 1/3, 1/3. So 1/3 of the children who are diagnosed with ADHD would move into adulthood without any problems at all the symptoms would have gone. Then there'll be another 1/3 who would have some problems and might need medication but can manage without medicine. And there'll be 1/3 who would need to continue on medicine for a longer period of time. But the key thing that changes as they move on to adulthood is hyperactivity usually decreases with time. But if there are some symptoms left, they would often be attention problems or disorganization that would continue later on in life. And again, then we have to bear in mind about the comorbidity. If there is anxieties, there is depression, and they're not treated, then they're more likely to continue in a longer period of time. And key thing, which I didn't touch on earlier, is substance misuse. I do see lots of children who have ADHD and have not been diagnosed or treated properly, and they often end up using cannabis because that somehow calms them down, and it almost acts to elevate their anxiety, and then they continue to take it. But then if they're giving medication, it's easier for them to get off that habit. The next question is, I would like to ask about how we help our children with staying focused on tasks like homework and household jobs during the teenage years. Knowing this is difficult for all kids at this age, but with ADHD, this takes it to another level, and I worry about developing the ability to learn important life skills. There are a number of things in this question. One is teenage. We know how teenage can be tricky, and how managing or supporting children in teenage is difficult. But one way of understanding the teenagers is that because they're moving from childhood to adulthood, this is a phase between those two, and they oscillate between being adult and being children. So there'll be times when they would present as if they are adults, and there'll be times when they will behave like children. And often parents struggle with this because we expect people to behave in a particular way and have a consistent pattern, whereas in teenage, that pattern isn't there because children are developing. They're trying to find their identity. So that is one thing. If the parents use that understanding, then it's easier to understand the child's behavior and to support them. Sometimes they need to be treated like adults, and sometimes they need to be treated like children. So that's just for teenage. Now, when it comes to ADHD, we do need to check whether the ADHD is being managed well. Has the child got good enough medication for ADHD? Is it effective enough? And the other thing is, are there any comorbid conditions like anxiety and depression? Sorry, I keep on going on about that because I think that's so crucial, and in all these cases it is. And once we have helped the child with their mental health, once we have supported them in that way, then they should be able to, on their own, develop the ability, learn important life skills, because they are themselves under lots of peer pressure to do these things. It's not just parents who are expecting them to behave in a particular way or learn these skills. Other children are also kind of putting some pressure on them, or even in schools and colleges, the things come. So again, going back to the teamwork, it's important that you as parent, you as professionals, you as teachers, all of you work together to support the children or young people in achieving what they need to do, or in achieving the academic targets. Now I'll move on to the next question, which is, I would also like to hear about regulation of emotions and ADHD. Well, the simplest answer to this question is emotional regulation is difficult in children with ADHD, just like it's difficult for them to manage their behaviors, and it's their inability to do that. Now, what this means is we as parents have to do much more than we would have had to do for a child who didn't have ADHD. So if we take a stormy sea and a small boat is trying to come alongside a ship, and in the stormy sea, if the ship is moving a lot and the boat is moving a lot, then it will be difficult for the boat to come alongside this the ship. So the ship in that situation has to be stronger, has to be more stabler, so that the child, or in this case the boat, is able to come alongside it. So often we do recommend for parents to go to ADHD groups or get additional parenting support and skills to help their children, because we don't at all ever say or suggest that the parent is not parenting well. But what we say is that we as parents are as good as our child's behavior. If a child has problems, if they have difficulty, if they have behavioral difficulties, then we with normal parenting skills or average parenting skills probably would not be able to support them enough. So we do need to upskill as their needs are more. So upskilling of parenting techniques is important. There are lots of courses around that, and you can go to those groups. We can recommend some of the groups if you would like to hear more about that. Moving on to the next question, and we have about 5 minutes left, so we'll see how much time this question takes and then whether I can take any more questions. Can you share some behavioral techniques to be able to use at home? So that's a question. And often the model that we use is called ABCD model. So it's based on what is the incident, or what is the particular action at that point, what happened, what was the behavior, what actually led to the behavior, and what was the consequence of the behavior, and finally, what did we learn from it? So let us say a child broke a glass. So that is a behavior. Now to understand it and prevent that from happening again, we need to find out what led to the child breaking the glass and what happened after the glass was broken. So if the child was lifting the glass, accidentally it fell down and the glass broke, that we know it's an accident. But if the child particularly went to the table, picked up the glass, dropped it on the floor, and it broke, then it's a different thing, different scenario. But again, understanding what led to the particular behavior, and then what was the consequence, as in how did you as a parent respond to the child. And then what we recommend is that if it's the same behavior again and again, then it's best not to be very critical at the time the behavior has happened, at the time when everyone's emotions are up, and that's not a good time to be talking about what to do next time. But what we say is wait for a time when everything is calm again, then talk about the event, talk about the behavior, talk about what led to it, and also ask the child what would help them so that they don't do the behavior again. So it's again a teamwork, and if you need any help, you can talk to a behavioral therapist who can support with this, because it is a process, but it's possible to do that. I'm moving on to the next question now. It says the next question is signs of ADD rather than ADHD, how to distinguish ADD from ASD and sensory processing disorder. Again, this is something that needs much more comprehensive assessment, and this would be done by a clinician to differentiate these different forms. Just to add to that, often children with ADHD have a higher chance of having ASD, and similarly with children having ASD, they might have a higher chance of ADHD. Hence, it's important to bear that in mind. Clinicians do that, and they do assess for both, or at least bear in mind that is there any symptom suggestive of the other as well. Next question is, are there any long-term consequences of beginning medication at age 9 years? Does medication impact on personality? Is medication the best treatment, or are there alternatives? ADHD is one of the most researched conditions in the world because of these kind of worries. And lots of research that's been done suggests that most of the medication that we used in UK are quite safe to be used. They don't have any major long-term implication. As I mentioned earlier, sometimes stimulants might have an effect on the growth, and then we monitor it regularly. And if there's a problem, we would stop the medicine. Medicines don't change the personality. They could help improve the personality, because if the child's ADHD is managed well, their social skills would be better, and they'll have better social groups, and that will make them feel better about themselves. So in that sense, yes, it might help with their personality. And there are alternatives to medicine. Medicine in ADHD, sorry, I forgot to mention it, the medicines don't treat, as in it's not a cure. Any medicine is not a cure for ADHD. ADHD gets better on its own. Medicines only help the young person to focus, because till they don't focus, they can't learn. So it's helping them focus. It's helping reduce the impulsivity so that they don't get into trouble, and then they can achieve in life, academically and socially. I'm aware we're reaching the end of the session. It's almost 6 o'clock, and we would like our co-founder, Greg, would like to say thanks to you as we're rounding up things. And do keep on sending the questions. Often I would try to get back to you with the answers. I might not be able to answer all the questions, but we'll try our best to respond to your queries. I know there are some questions that have been set here, but I will hand over to Greg if Greg is there. Yeah, Greg is here.
It's so reassuring to hear from your vast experience over many years and thousands of work with families. And it's very clear that you draw upon what you have learned together with them to come to helpful solutions. And I think it's typical of a holistic view. I'm particularly impressed hearing about that a big part of the solution in many cases is the self-care and the parental support, which is obviously crucial to the child, and that those things are available. And I'm sure in our information that we put out subsequent to this, including the recording of this session, will include some details there. Your wobbly boat analogy reminded me of some of my experience as a parent, and I'm sure there are calmer seas to be had as well. So we'd like to thank all the parents and people who have joined today. Your questions help us learn things and help us reflect on the support which we offer at Welltech Medical. And we are considering doing another focus ADHD session, as well as the ones which we've already talked about, because there's clearly an area of huge interest. And most particularly, there is no one answer or blanket answer, but there are many different solutions. And what Welltech Medical focuses on, and Dr. Warikoo, I know, is very passionate about, is finding the specialist support for individual needs, the individual needs of the child and the people, carers and the families involved in looking after them, and indeed the schools who play such an important role in that crucial teamwork. So thank you very much for joining us. Thank you very much, Dr. Warikoo. And we will send out all the links for further information, including a recording of this session, to everyone who participated today and that will take us a few days to arrange. Thank you very much.